Yes, we can hear you.
All right, great. Good afternoon. Thanks for joining us. We're doing our weekly update from the health department. And today we will just give you a bunch of updates. They seem to be coming in real time. So pardon me if I get something that is corrected in just a few minutes. But obviously there's a lot going on today with regard to vaccine booster doses, et cetera. Let me share my screen and we'll just start with some of the data that we're looking at and just go from there. Can everybody see the state map here and the R effective?
Yes.
Hopefully so. So our region has finally dipped below the 1 for the R effective, which is good. We're now, I think, in line with the rest of the state, which has been under 1 for a while. Just in terms of where things are in Fresno County, here they have hospitalizations at 375. When we did our media about an hour ago, we said 366. We know it's in the very high 300s, but it's not as high as 400, which is where it peaked out just about a week ago. In terms of where things might go with hospitalizations, we're certainly hoping that this projection is accurate and that hospitalizations for COVID at least will decline as we get into October. But we also know that flu season has started. In fact, we had our at least one flu patient at our hospital, and I'm sure we're not the only one with a detected positive influenza swab. So just be wary that flu season is here. That's why we did the flu mandate, and for all healthcare workers, please start organizing your flu clinics and getting your staff vaccinated, because that's something that we do need to guard against. We did such a great job last year that flu really wasn't a factor in the winter surge that we had with the COVID patients. We're certainly hoping that we can repeat that by getting everybody vaccinated who's eligible, and the healthcare workers are mandated to get their vaccines. So please work with us if you have any questions about that. In terms of ICU forecasts, again, ICUs are very heavily impacted. We certainly hope that this line where it shows ICU numbers going down holds. I was asked some very pointed questions about crisis care standards on media today. And, obviously people want to know, if we're going to flip into crisis care standards and whether it's going to be at the hospital level or at the county level. And these are not easy yes or no questions. I mean, these are basically very calibrated and balanced decisions that no one person is going to make on their own. But we know that we still remain so impacted that we still do have to think about possibly going into crisis care standards. The specific criteria that I know about are, if there's more than 3 days where we just have no ICU capacity and a large number of ICU holds in other areas of the hospital, that would trigger us to go into crisis care standards. But it's something that we're going to have a lot of deliberation and meetings before we actually pull that trigger if we need to. But hopefully, if we can just slide through and get into good numbers from the COVID perspective, and hopefully as the fall takes away some of the summer trauma and other summertime presentations, that hopefully we'll be in a better space in terms of hospitalizations. So that's kind of the hope, and these are the projections. You can find them on CalCat. That's where we go to get all of our different projections and things like that. Let me now go to just the individual numbers for Fresno. So here you again see what our hospitalizations have been doing. We did have a little plateau, and now they seem to be hovering in the high 300s. And we certainly hope that that number keeps coming down. The ICU numbers are at 81, which is still very close to the peak that they had of 90 something for COVID patients. Again, I really wish that the state would generate like total numbers, not just COVID numbers, because I think that people that aren't aware that the total numbers are just so high that the hospitals are really dealing with record volumes in terms of their census, and that these numbers don't tell the whole story. They tell just the story of COVID, but we know that there's a lot more that's going on in all of our clinical practices, not just hospitals, but especially as we worry about our acute care hospitals getting severely impacted by this surge. Let me flip over to our vaccine dashboard, because we actually crossed a very important milestone and we were able to deliver our 1 millionth vaccine here in Fresno County. And we're now on our way to hopefully vaccinating more and more people. We still have a ways to go. So eligible people are at 64%. We really want to get to 75 to 80%. 100% would be great, but even 65, even 75 to 80% would be fantastic. And then in terms of overall population, remember those under 12 are not eligible for any vaccines yet. We're only at about 50%, which leaves hundreds of thousands of individuals vulnerable to catching COVID. And so we're still working very hard to get vaccines delivered. And really, all of you are helping us. And thank you for doing that by having those hard but important conversations with patients and really convincing them through your credibility and the extent of your knowledge that as a person that they can trust, that you're telling them that vaccines are important. We really appreciate you doing that, because that's really how we're going to get to the last few 100,000 people that we need to get to. So the FDA has been meeting all day. I don't know if their meeting has finished, but if you haven't heard, they basically did several votes. And the first vote that they did was basically to say that they're not going to recommend boosters for every single person that got a Pfizer vaccine earlier this year. Then they went back and re-voted, and they said they are going to vote to approve boosters for the elderly and those at higher risk. So this reminds me of the tiered kind of eligibility criteria that we had whenever we first rolled out vaccines, where we said, we're gonna really focus on the high risk populations, and that includes individuals on the front lines of medicine, people that are essential industry workers, people that are in law enforcement, our pre-hospital providers, our grocery workers, our bus drivers, and really those that are at high risk of severe COVID, our immunocompromised individuals, which kind of have their own eligibility already, and then our elderly 65 and older. So this is who boosters are being recommended for. And so we're working on a press release that we will share with you that will basically cover this. This is happening in real time. As you can see, it's being updated minute by minute. So I don't expect any grand dramatic changes from this policy for this weekend. Remember, this only applies to Pfizer, and it only applies to third doses for people that are elderly, high risk of severe COVID, and those who are immunocompromised should already have gotten their not booster, but their supplemental dose. And so that's kind of how we're looking at it right now. What do we do about Moderna patients? We ask them to wait. What do we do about Johnson & Johnson patients? We ask them to wait. However, I do want to share with you this article from the MMWR, which just came out today. So this actually asked, we've been talking about breakthrough infections for many months now, and we know that the landscape has really changed with Delta, which kind of came on the scene in March, April, and then hit the West Coast a little bit later. So what is going on with breakthrough infections with Delta in like normal patients, those without immunocompromising conditions? And so they basically looked at this, and they were able to say, it looks like the vaccine effectiveness for the general population holds up pretty well. With Moderna, the vaccine effectiveness is 93%, and with Pfizer product, it's 88%. With Johnson & Johnson, also known as the Janssen vaccine, it goes down to 71%. So very, very euphemistically, the CDC is saying, although these real-world data suggest some variation in the levels of protection, they're all pretty good, and they provide substantial protection against COVID hospitalization. I have to admit, I haven't done a deep dive into this paper. I'll definitely link it to you. It came out just this morning, and I just saw it. But basically, what they're showing is Johnson & Johnson is most likely going to need a booster for everyone. That's how I read this. For Moderna and Pfizer, it looks like vaccine effectiveness pretty much holds. And here they're looking at antibody concentration, not breakthrough infections, although obviously the two are linked. But you can see antibody concentration goes down with the Janssen vaccine a little bit more than it does with Pfizer and Moderna. Skipping back up, sorry to make you dizzy, but here's the actual table where they break down Moderna versus Pfizer versus Janssen, and then they're able to calculate this score called vaccine effectiveness, which holds up in the 90s for Moderna, 77 to 88% for Pfizer, and then 68 to 71% for Janssen. So I think we're going to hear in the next couple of weeks that all Johnson & Johnson patients are going to need boosters. and that probably higher risk patients for Moderna and Pfizer are going to qualify or be recommended for boosters. I think that's where things are going to land. But again, I'll share exactly the information that I have so you can make your own conclusions. What are you going to do next week? Well, if you have a Pfizer patient who's at 6 months or longer for their timeline, go ahead and give them, as long as they qualify, if they're 65 and older, or they're a healthcare worker or on the front lines, go ahead and give them a booster. I think we have the go-ahead from the FDA. That's how I'm interpreting today's news. And then for everybody else, just ask them to wait, and hopefully we'll have more clarification about every single category of patient so that we have very good and consistent regulations about who actually needs a booster. And then, the big question is, why don't we just do antibody levels on people? Obviously, this paper did antibody levels. That would actually show us whether somebody is immune or not. And as soon as their antibody levels drop off, you just give them a booster shot. And that's a much more scientific way to go about this. The answer is, I don't know. The answer is, I'm not sure that technology is able to scale up beyond clinical trials, and whether the antibodies are considered so reliable that we can actually use those titers as a way to give people booster shots. That's basically what we do for measles, mumps, and rubella, and even hepatitis vaccines. We actually check antibody levels before we decide that somebody needs a booster. I think that's where we are going to go with COVID, but it's anyone's guess how soon we'll get there. And in the meantime, I think people are just making educated guesses because it's just cheaper to do it that way than to roll out a whole antibody testing program and then all of the controversies and problems that would introduce into the system. Any questions about those topics? I'll open it up for comments and questions. And then I'd really like to get an update about monoclonal antibodies. The people that I want to hear from are, for those of you that are doing them, what are you observing in terms of demand, and also what problems are you running into, or what roadblocks you're running into? And then if Dr. Zweifler is on, I'm not sure if he is, he may have some updates about some of the changes that the state is going to make in regards to how antibodies are going to be supplied for our monoclonal antibody providers. I see Gail has her hand up, so go ahead, Gail.
Hi, good afternoon. Earlier on in your report, I think you started off by talking about the flu and that we've had one positive case that was acknowledged yesterday. Is that correct?
Yes, that's what I'm aware of. I need to check back with our epidemiology division to see if there's more than one case. I get the feeling that there probably is, but I just haven't heard about them.
Well, I wanted to clarify it that this morning within the hospital system, they did say that was incorrect, and that thankfully we don't. So that did, it was incorrectly reported. It did test negative. So I just wanted to make that clarification because.
Oh, thank you. Yeah, thanks so much. Whenever we got that first report, obviously we were taken aback, but honestly, not that surprised. I mean, this is the time when flu will start to present itself, is in, probably late September, early October. And then, it'll just be one patient after another who will come in with a flu-like illness. And then we will have to test them for influenza and COVID and other respiratory pathogens, et cetera. So thank you for that, though. I appreciate you updating us, Gail.
Absolutely. Thank you.
Sure. Any other questions or comments? All right. Let's talk about monoclonal oh yeah, go ahead. I heard somebody unmuting.
Just one question.
Themselves. Yeah, go ahead.
This is Enrique from the nephrology group. The question you had about the antibodies, the monoclonal infusions, is the worst that we hear is that the shortage. We've been turning patients away, and we've been trying to borrow medication from different places. I just want to know the timeline, or what can we do to obtain what we need, because we're usually doing between 20 to 30 patients a week.
That's interesting. So are you hearing from the manufacturer that they're not able to supply you, or who's giving you that information?
Yes, the last mail that I got was that our local department will be adjusting the doses for us.
Yes, that is correct. And so this is kind of interesting, because we were very heavily involved when monoclonal antibodies were first provided. And then we basically, I'm talking about the health department. The health department was able to kind of get out And then the individual providers like yourself were able to order from the manufacturer directly, which seemed to work out pretty well. Now with increased demand and other shortages, et cetera, I think they are going to bring back the allocation scheme and then have local health departments actually kind of be the distributing agency. And so we are going to be working more closely to help distribute the monoclonal antibodies. But please reach out to us and email us about your situation and what your needs are, because my team is actively working with the state to tell the state that, you know, that what our allocations are. I don't know, which kind are you using? Are you using Regeneron or are you using the BAM estimab?
Well, I'm using the Regen, and I have plenty of BAM. I'm just need to see if I can actually get the SD to compare with the BAM.
Well, the BAM and the SD, yeah, we have 25 doses that you can have right away that we didn't get to allocate this week because nobody wanted them. So if you want the BAM SD combination, I think we can probably get you some right away or as soon as possible.
Yeah, I have plenty of BAM. I just need the SD.
Okay. Okay. Well, yeah, please, if you could reach out with a quick email, I can get you in touch with Matto, who is in charge of this program from our side, and certainly get you the information and the supply that you need.
Okay, I'll have Meg reach out to you guys. And
are you with you said you're with the nephrology group? Are you with Dr. Dinger's group? Or okay.
Yes.
Okay, great. Okay, thank you.
Thank you.
Yeah. Anyone else? Anyone starting to do MABs or having patients ask about it? Okay, well, we have a handful, I think between 6 and 12 providers that we know about, although there may be others that we don't know about. At this point, we do need to know about all of you because we're going to be the ones from the health department. My team is going to be responsible for making sure that you have a steady supply until some of these shortages get resolved. So hopefully we can work together. I'm really proud of how people have stepped up and really flex their resources to offer this treatment. I really do believe it's an important tool in our toolkit. And, you know, with the recognition that COVID is not going away, I really think this is something that we just need to invest in and make happen as just another tool in our toolkit, you know, for patients that as soon as we identify them as having COVID or high risk of COVID due to close contact, if they are at high risk, just give them antibody in order to help prevent a potential hospitalization down the line. I know that that's hard to do. That's one of the real challenges with this medication is that given the previous structures that we've developed before COVID came along, there's really no good home for this medication. You know, it's really hard to put these patients into an infusion center. It's hard to have them in the emergency department. It's really hard to get them to go into a primary care setting or even an urgent care setting. I understand how hard it is. So I really appreciate all of you who have stepped up in all of those different settings to try to make this happen. And hopefully it'll get easier and easier as we get more experience and as we are able to give people realistic expectations about what they need to do to get the monoclonals. All right, any other topics or issues related to COVID? We are doing a lot of flu vaccinations as well. I think if Sim is on, hopefully he can drop some of that information into the chat related to our flu clinics. I'm going to try to find the flyer myself if I can. But we have over a dozen flu clinics planned. So if you're, you know, obviously we want you to offer your own flu shots if you can, but we understand that they may not be realistic for everyone at this time. We've heard about some providers just being told that flu vaccines are not yet available for them, but they will be available shortly. I know the pharmacies are already getting them, and that's usually how it happens, that the pharmacies get them first, then the clinics get them, and then the health department gets them last. but we're already planning our flu clinics. And we have over a dozen planned between late September to early November for people to just drive up or walk up and get a flu shot. And we know that all of the hospitals do excellent, just really, really hit a home run every single year with getting all of their healthcare workers vaccinated. So we really look forward to having a very successful flu season. But if you need help with referring people across town to a flu clinic, then that's basically why we've set up these mass vaccination clinics. I don't know if I mentioned, but we've also gotten confirmation about one case of St. Louis encephalitis. St. Louis encephalitis is like West Nile virus. It can cause like an encephalitis syndrome, a flu-like illness, and even gastrointestinal syndromes. So just something to think about, especially, it's kind of hard because obviously a lot of people don't remember being bitten by a mosquito, but this is a mosquito-borne illness, just like West Nile. And in a patient that's elderly or frail or has comorbid conditions or is very, very young, if you're doing kind of a sepsis/meningitis workup and you happen to do a spinal tap, then you may want to check them for both West Nile and St. Louis encephalitis. We had one patient that was positive already, the very first one in the county and the very first one in the state, as far as we know. All right, any other questions or comments from our community? Okay, I guess it's going to be a relatively short call, and I'm okay with that, so we can all get our weekends off to a good start. Next week, we're going to do a deep dive into climate and have presentations related to climate health, as we did before with some of our UCSF Fresno residents. And I'll be doing a little bit longer PowerPoint-based talk about climate health issues, especially the contributions that we can make in healthcare to help with climate concerns. So I'm looking forward to that. I really feel like even though we are knee deep and neck deep in COVID, that this is not the only public health issue that we need to be focusing on. And so I'm always happy to, give a platform and focus on other non-COVID related issues. I feel like that's just as important to do. And these meetings give us a great opportunity to learn from each other. So if you have anything that you want to focus on or present about, please reach out to us. We'd love to hear from you. And we always love to hear about initiatives and projects and opportunities that our medical providers share with us so we can amplify and magnify those. Well, if there's no other questions or comments, I think we will go ahead and adjourn. And I wish everybody just a very happy and restful weekend. Please enjoy the nice weather, and we'll see you again next week. Thank you.
Mm-hmm.